Welcome, everybody, to this first of the year Emerging Scholars visit. For those who are not familiar with the Emerging Scholars Program, this is a program between UCSF, University of Michigan's Institute for Healthcare Policy and Improvement, or Health Policy and Improvement, IHPI, and the Leonard Davis Institute at the University of Pennsylvania. So each year, each of the universities involved in the program selects two scholars to be our emerging scholars for the year. And those scholars are then one goes to University of Michigan and one goes to Penn to visit. And then we get back from them a scholar from Michigan and a scholar from Penn. And to apply for this next year, keep your eyes on the IHPS newsletter. If you are not an affiliate of IHPS, you can go to our website and apply for affiliation. And because that will be you need to be an affiliate to apply next year, starting next year. And that enables you then to get this funded trip to go visit other scholars. The program really is meant to provide an opportunity for scholars who are assistant professors, typically at the later stages of the assistant professor trajectory, to network, to meet other people, to share their research. And I know of a number of collaborations that have come out of people meeting each other during these visits. So, and plus San Francisco is really nice to visit in the spring. So people from Pennsylvania and Michigan are always happy to come and see us. So we are really fortunate today, or at least I feel like we're extra fortunate because today we have Lauren Gerlach. She is at the University of Michigan, and she is an assistant professor in the Department of Psychiatry at the University of Michigan. And her expertise is really geriatric psychiatry. We are, I think, one degree of separation from each other with co-authors, and also are both in a proposal together. So maybe we'll get to collaborate with each other starting this winter if we're lucky. As a geriatric psychiatrist, her research program is directly informed by her clinical work and her experiences with patients and families and other care providers throughout the healthcare system in order to deliver high quality care for older adults. I'm not going to really belabor her bio because it is, she's actually exceptionally accomplished, and I could go on. And I really want to hear her presentation. So welcome. Thank you so much for coming.
All right. Well, thank you so much for having me, and I'm so glad to be able to have the opportunity. I can also validate that it's much nicer here now in the spring than it is in Michigan, so can appreciate that. So today I'm going to talk some about my research, really understanding central nervous system active medication prescribing to older adults with mental health and cognitive disorders. And while I can't see the chat on Zoom, I'm told that we'll go through those questions at the end, and happy to take any feedback or questions that folks have. So no disclosures, but I will discuss off-label medication use. And so this is often what an outpatient visit to geriatric psychiatry can feel like. For many of you who work clinically, this may look familiar. And so very early on in my clinical training, I was really struck by how much the medications that we prescribe in psychiatry can help our patients and also sometimes cause problems as well. And my research really focuses in three main areas. So part of my work is really trying to understand trends and appropriate use of what we call central nervous system active medications. And those really include all of the medications that we prescribe in psychiatry, plus prescription opioids. I'm also very interested in understanding both the clinical and non-clinical factors that influence prescribing. So how do patient, clinician, health system, and policies all influence the care that patients with mental health and cognitive disorders receive? And then the focus of my K23 and another area of interest is really on understanding prescribing in the end of life period and some of the unique challenges with delivering end of life care for dementia. And also I'll talk about some of my research in each of those areas. So my overall research mission is really to generate evidence to inform policies to help improve prescribing safety and outcomes for older adults, both with mental health and cognitive disorders. And my work uses a variety of data resources, which I'm sure many here and listening are experts in. And so that combines administrative claims data, survey data, as well as some primary data collection, including mixed methods and qualitative work. So, starting off first about some of my work and trends and appropriate use of psychiatric medications. So, first off, what are central nervous system active medications? So, these are generally medications that work in the brain and pretty much include all of the typical medications that we prescribe in psychiatry. So, things like antidepressants, antiepileptics, mood stabilizers, antipsychotics, benzodiazepines, and prescription opioids. And many of you may be familiar with what's called the Beers criteria, which is a set of prescribing recommendations and guidelines that really highlights how some of these medications can cause significant harms for older adults. So we worry about things like falls, sedation, impacting cognition. These are things that are really fundamental to keeping older adults independent and having a good quality of life. There's also a growing recognition that use of these medications, not only alone, but in combination, what we call CNS active polypharmacy, can be particularly dangerous to older adults. And so in 2015, the Beers criteria, spearheaded by Mike Steinman here, came up with an update that included a measure of what we call CNS active polypharmacy, which is use of three or more of these different medications. And that's really because additive use of these medications can put older adults at even worse risk of poor outcomes related to medications. And so the good news is we know that this current generation of older adults are more accepting of mental health treatment. And certain current studies show that maybe 1 in 5 older adults are prescribed a psychiatric medication. So there's less stigma and better engagement in mental health treatment. The downside of that is that sometimes there's overtreatment. And so we're particularly interested in how use of CNS polypharmacy has changed over time. And so, for a couple of studies that we've done, we've used what's called the National Ambulatory Care Survey, which some of you may be familiar with. It's an annual survey of office based physician visits and really includes a lot of helpful information about the type of care received and medications. And we looked from 2004 to 2013 to look at visits that included polypharmacy dispensed. And so, again, that's three or more of those medication classes that we've talked about, things like benzodiazepines, antipsychotics, mood stabilizers. And so what we found is that combined use of these medications is really increasing significantly over time. So among patients over the age of 65, use of polypharmacy has really doubled. And when we look across demographic groups, it turns out that patients in rural areas are really the ones that we're seeing the most increase in medication use. And we know that those are areas where it can be very difficult to find mental health providers. And there's plenty of other social and economic factors that could be contributing as well, too. A colleague and friend of mine, Ilsa Weichers, who also works in some capacity with the San Francisco VA, and here, has often said sertraline is not a good substitute for Meals on Wheels. And so, thinking about kind of what exactly we're trading. We've also seen some alarming trends in increased prescribing among patients with no mental health diagnoses or no pain diagnoses. And so that kind of begs the question, what exactly are we treating? And there's kind of this idea of treating these non-specific kind of symptoms of distress. Ashwin's done some really interesting work in loneliness and social isolation. I think one of your studies has also shown that as well, that increased prescribing of benzodiazepines, polypharmacy amongst patients who are socially isolated. When we look at who's actually prescribing these medications, it's actually non psychiatric providers who are providing the majority of mental health care and psychiatric medication prescribing. And that's both a preference and a workforce shortage issue. And so, some studies I've been involved with, we've done surveys through AARP, and you talk to older adults, and really folks would prefer to receive mental health care within primary care. And then, for anyone who's tried to refer a patient to a psychiatrist, we know that there's a huge workforce shortage. And so most of the prescribing is coming from non-psychiatric providers. When we look at what medications are actually contributing most to this growth in CNS polypharmacy, so what classes are really driving this increase, unfortunately, it's really benzodiazepines and opioids, which are the most common medications prescribed within there. We know those medications in particular have a very poor risk benefit profile for older adults. And these medications are also commonly co prescribed, which is concerning given risk of increased respiratory suppression with use of these medications, which has been highlighted by recent FDA warnings as well. So, as a geriatric psychiatrist, I spend a lot of my clinical and research time thinking about care for patients with dementia. And so, while no medications have been approved by the FDA for treatment of behavioral disturbances in dementia, we know that these types of central nervous system active medications are used very frequently. And so, while memory loss is kind of the cardinal feature of dementia, these what we call neuropsychiatric or behavioral symptoms, things like agitation, anxiety, hallucinations, are really universal across dementia types and stages. And some epidemiologic studies will show that 97% of patients with dementia will have at least one of these behaviors during their disease course. And these medications often get treated with antipsychotics, and we know that these medications have been around for a long time. So, this is an ad from the 1960s in the American Journal of Psychiatry for Thorazine. It says, "Tyrant in the house for prompt control of senile agitation." In another ad, this gentleman's referred to as Pop. You'll see an older man wielding a cane over his head. And the idea is that we're going to control these unruly men through the use of a sedative medication. And so, even though these medications are used very frequently, when you actually look at the evidence base for their effect in improving behaviors, unfortunately, it's quite modest at best. And so, when you look at pooled meta analyses, the effect size of treatment of these medications is actually quite small. For antipsychotics, an effect size of 0.18 means that 18 out of 100 patients with dementia treated with an antipsychotic will have improvement above and beyond placebo. So, not a very strong treatment effect. When we look at other central nervous system active medication classes, things like anti-epileptics, mood stabilizers, antidepressants, these medications have unfortunately even worse data to support their use in treating behaviors. And we know that these medications come with a whole lot of side effects as well, too. There's specific FDA warnings, black box warnings for antipsychotic use in dementia. And we know that these medications are associated with an increased risk of death. Even outside of the mortality risk, these medications can also cause other worrisome side effects like sedation, falls, extrapyramidal side effects that we have to watch out for. And really numerous expert bodies, whether it's the American Geriatric Society or the American Psychiatric Association, really recommend what we call non-pharmacologic or behavioral treatment strategies to help manage these behaviors. Non-pharmacologic really isn't a good term. It's named for what it isn't rather than what it is. We generally think of these as more patient with dementia, caregiver, and environmental supportive interventions. However, anyone who's worked in long-term care settings or in assisted living knows that it can just be so challenging to actually implement these behavioral interventions, that it takes time to train staff. There's a lot of turnover. Sometimes it's easier to write a prescription, and so it can be very difficult to implement these in real world practice. But knowing the underlying cause of the behavior is really important because it directs treatment. So, a urinary tract infection, an issue between communication with a caregiver and a patient with dementia, an environmental change, and psychosis should all be approached very differently. However, in real world treatment settings, we see Mario here with this antipsychotic. Often, this is the tool that's used to treat the behavior, even though it might have many different causes. And so we know across our studies, so even though there are no approved medications by the FDA to treat behavioral disturbances, we know that CNS active medication use is very common. Um, this slide shows the rates of use of these medications among patients with dementia in community settings, as well as long-term care settings, and pulls together some data from several of our studies. And what you can see is that use across both the community and long-term care settings is very high. 80% of patients in long-term care are receiving at least one psychiatric medication. There's been a lot of focus on antipsychotic prescribing in nursing homes. 20% of patients with dementia in nursing home settings are still receiving antipsychotics. And you have to remember the evidence base for these medications in terms of helping is actually quite minimal. And when we look at CNS polypharmacy, use of, again, three or more of these medications, about 40% of long-term care residents are receiving three or more of these medications. So we would hope with the high rates of use of these medications and the high risks, especially with the antipsychotics, that the things that would be driving medication use is really a clinical need, or that medications would be given to patients who really have a high clinical need for these medications. However, when you look at studies, especially in long-term care settings, it often has to do more with the characteristics of the nursing home than it does the patient's population or clinical need. And so there's been some really interesting studies done by Paula Rashan and Chen that have looked at prescribing culture and, for instance, getting enrolled or receiving care in a high prescribing facility regardless of your baseline clinical characteristics, just by virtue of being in that facility, you're much more likely to be exposed to these medications. But there's been some interesting studies also looking at staffing ratios and workforce issues as well. So, worse staffed facilities are more likely to lean towards these medications. And we understand it's very difficult to deliver these non pharmacologic interventions. And not surprisingly, all of this is worse during COVID as well, right? Staffing shortages are worse. Some of the studies that we've done have looked at there's been increased behavioral disturbances in nursing home residents during this time, especially corresponding with facility visitor restrictions. All of the use of these medications is really increasing since the time of COVID as well. So, given these high risks associated with certain medications, including antipsychotics, there's been several federal prescribing initiatives to try to improve prescribing, especially among long-term care residents. And a lot of these have focused specifically on antipsychotic use. So, I'll just try to give a little bit of a background and brief historical overview of how some of these regulations came about. So, since the introduction of OBRA in the 1980s, there's really been a concern raised that these types of medications, sedative medications like antipsychotics, were being used as a form of chemical restraint. And OBRA really introduced regulations for increased monitoring and oversight of use of these medications, as well as physical restraints. By the early 2000s, the FDA began to report mortality data related to patients with dementia who were participating in antipsychotic trials, finding that these patients were more likely to be dying from cardiovascular events, from aspiration events, as well as stroke. And then that led to the FDA black box warnings in 2005 and 2008 for antipsychotics. And out of this concern, there's been several more recent initiatives. So in 2012, there was the introduction of what's called the CMS National Partnership to Improve Dementia Care. In this program, specifically, the main goal of the program initially was really to try to drive down potentially inappropriate antipsychotic prescribing. In 2015, CMS then constructed a quality measure for dementia care, which is the antipsychotic prescribing rate in a facility. And that antipsychotic quality measure then gets tied into facility star ratings, where higher antipsychotic use is equated with lower quality nursing care. And so facilities are really incentivized to reduce their antipsychotic prescribing to either maintain or improve their star rating. And since the beginning of these initiatives, CMS has published that there really has been significant declines in antipsychotic prescribing. Now, the way that CMS generates the long stay antipsychotic quality measure is that in the numerator, they look at the number of long stay residents, and generally that's folks who have been in a nursing home for over 100 days. Who have an antipsychotic, who have evidence of receiving an antipsychotic. And the way they capture that is through something called the minimum data set, which is a federally mandated assessment that's completed regularly for all nursing home residents. And for those who haven't used the data source, it really contains a lot of rich data on functional data, cognitive data, includes information about medications received, and really can be a rich data source filled out by nursing or staff caring for the patient. The denominator is the number of long stay residents in the nursing home facility. And there is some recognition from CMS that there's certain conditions where use of these medications might be clinically indicated or appropriate. So CMS has categorized three exclusionary diagnoses, which include Huntington's, Tourette's, and schizophrenia. So these are all diagnoses that have very low prevalence in the general population. So I'll just make a couple notes. So one is the CMS National Partnership to Improve Dementia Care. So even though dementia is in the name, you'll see dementia mentioned nowhere here. So this measure does not specifically restrict to patients with dementia. This includes all long stay residents. You'll also notice in the denominator that there are notable exclusionary conditions that are missing. So for instance, where antipsychotic medications might be appropriate or even FDA approved for treatment. So for instance, major depressive disorder or bipolar disorder, patients with those conditions are not removed from the denominator exclusions. Also, patients in hospice are not removed from the denominator as well, too. We know antipsychotics are used very differently in end-of-life settings for treating of both behavioral and physical symptoms. This information is then publicly reported on the Nursing Home Compare website, and consumers can then use this information to make decisions about selecting facilities. So, part of my work and interest is really trying to understand the impact of policy on prescribing. And in a recent study, we really tried to understand how some of these federal prescribing initiatives have impacted national trends in antipsychotic and other CNS medications among long stay residents. And in this study, we specifically looked in the Veterans Health Administration. So outside of CMS, other health systems like the VA also have similar type of prescribing initiatives trying to improve the safety of prescribing to veterans who receive care through what are called community living centers or VA nursing homes. They also generate a percent of CLC residents who receive an antipsychotic medication. They do the similar minimum data set assessments, and then they also post those publicly to a website called CLC Compare. So very analogous to what is done in CMS nursing homes. And so we looked from 2009 to 2018 at all veterans who were long stay residents in a community living center and looked at the changes in medication prescribing over time in the setting of both CMS and VA initiatives. And one VA specific initiative I'll call out is something called PDSI, or the Psychotropic Drug Safety Initiative, which was really spearheaded by Ilsa Wikers, which really takes a look at certain high risk medications like antipsychotics, benzodiazepines, and really tries to reduce prescribing in the VA as well. So, what did we find? So, on the x axis here, we have time. On the y axis, we have the percent of veterans with dementia who are receiving a various medication class. The first kind of section of the graph is before the 2012 CMS National Partnership. The first line then designates when that initiative started. And then the last section is, again, the introduction of these VA specific initiatives like the Psychotropic Drug Safety Initiative. And what we see, and this parallels what we see in CMS data as well, too, is that there has been actual declines in antipsychotic prescribing among long stay residents with dementia since the introduction of these initiatives. A little hard to tell in the graph, but this is really accelerated after the national partnership and after the VA specific initiatives. But how about when we look at other medication classes? So this is looking at anti-epileptics like mood stabilizers, medications like valproic acid, gabapentin. We find that unfortunately there's really kind of this substitution or accelerated prescribing of other medication classes. And again, even though the trend was going up before the national partnership, this is really accelerated after that time. When we look across other medication classes, you'll just see that use of CNS active medications are very common amongst patients with dementia. So the top line there is showing overall central nervous system active medication use. About 80% of veterans with dementia are receiving at least one of these medications. The next line down are antidepressants. And again, we see some acceleration after the national partnership and the VA initiative, where about over 60% of veterans are receiving an antidepressant. The next line down is opioids. And so we actually see some acceleration in opioid prescribing after the CMS national partnership and only starting to plateau and start to reduce after the start of some of VA prescribing initiatives like the Opioid Safety Index. Probably one bright light or shining point on this graph is the line for benzodiazepines and anxiolytics, where we actually do see sustained decreases in use, which is great because we know that these medications have a particularly high side effect profile, especially for older adults with dementia. And then ironically, the last line on here is the only medication that's actually FDA approved for treatment of dementia, which are memory medications like cholinesterase inhibitors and memantine. And so use of these medications were the lowest out of all of these classes and also significantly decreasing over time. What's not shown on this graph was we also looked at CNS active polypharmacy. So again, use of 3 or more of these medications, and about 40% of veterans with dementia are receiving polypharmacy, and that's also increasing significantly over time. So when we look at the individual agents that are most contributing to some of these changes, when we look by antipsychotics, the most commonly prescribed antipsychotic is quetiapine or Seroquel, which is probably not surprising to most folks who work in long-term care settings. Haloperidol was second. So when we think about anti-epileptic prescribing, what's really contributing to this growth? Turns out it's all due to gabapentin. So gabapentin is really doubling over this time period. And we know gabapentin and gabapentinoids really get used for a variety of purposes. So they're only FDA approved for a very narrow indication of post-herpetic neuralgia, as well as other seizure disorder. But most of it gets used off-label for pain, as well as treatment of certain behaviors like anxiety, insomnia, and much of this is being used in off-label conditions. We also saw significant increases in valproic or Depakote prescribing as well. When we look across antidepressants, most of the growth is due to increases in sertraline prescribing and then sedating antidepressants, so things like mirtazapine or trazodone. Kind of the plummeting green line that you see here is a little bit of an artifact of an earlier FDA warning, so that's specific to citalopram. In 2011, there was an FDA warning that showed that high doses of citalopram were associated with QTc prolongation, and so prescribing of citalopram really reduced. But most of the growth of antidepressants is around sedating antidepressants, which again are likely being used off-label to treat some of these behavioral symptoms as well. So main takeaways from this work. So while antipsychotic and benzodiazepine prescribing has decreased among veterans with dementia in VA nursing homes, unfortunately, this has been matched by simultaneous increases in other medication classes, which again, don't have a great evidence base in treating some of these behaviors. And it raises concerns that policies that are only focused on reducing antipsychotics may shift prescribing to other classes, and that really in thinking about quality metrics for dementia care, we really want to think about a broader range of medications. And I just want to say this is not a VA specific problem. So work that we've done in CMS, it also shows these same patterns where we see increased prescribing of anti-epileptic medications. Dan Harris, who's at Brown, has done a study looking at Ontario nursing homes and also has found increased prescribing of anti-epileptics and sedating antidepressants. And it's important to note that while antipsychotics are tracked and very much impact nursing home ratings, anti-epileptics are not tracked. And so that's gone somewhat under the radar. So a colleague of mine refers to this as whack-a-mole. So kind of as we exert pressure to decrease prescribing of one class, providers might just shift to another, especially when incentives aren't aligned to kind of promote or provide space for non-pharmacologic treatment strategies. So I've provided some evidence that CMS, the antipsychotic quality measure, can lead to some unintended effects in terms of growth of other medication classes. I'll go through a few studies to show that this has also led to some increased reporting of exclusionary diagnoses, as well as spillover to populations that weren't originally intended by these initiatives. So again, just to remind us how the quality metric is measured. So we have the percent of long-stay residents who are receiving antipsychotic, and then there's three exclusionary conditions that are recognized, which is schizophrenia, Tourette's, and Huntington's, again, are all diseases that have a very low prevalence. And so there's been some studies done to start to look at this. And so a study by Winter in 2019 using Virginia Medicaid claims data found that since the beginning of the CMS national partnership, the diagnosis rates of schizophrenia, Huntington's, and Tourette's has basically increased 40% over that time. And so it'd be very hard to believe that there's been an increased prevalence of these disorders. So again, kind of gaming the system some. Shekinah Walters, who is at University of Minnesota, did a study looking at national Medicare data, looking at diagnosis rates of schizophrenia shortly after the initiatives, and found that basically diagnosis has doubled since the start of the national partnership. And this has disproportionately been reported among Black nursing home residents as well. Patience Moyo, who's at Brown University, has recently looked at this at the VA and found similar findings as well. And I'm involved in a study with some collaborators at Brown, where we're currently looking at this as well, looking at new diagnoses of schizophrenia, Huntington's, and Tourette's, bringing in claims data from the previous 2 years and seeing similar findings. So kind of shifting to other diagnoses as well. We've also done some work to try to look at how this is potentially spilled over to other populations not intended by these quality measures. So again, hospice or enrollment in hospice is not an exclusionary condition. And we know hospice, so it's a domain of palliative medicine, which is really focused on symptom control for patients who are in the last 6 months of their life. And we know that antipsychotics are used very differently in hospice. They can be used for both behavioral and physical symptom management. And hospice nursing nursing homes are a very important location for the provision of hospice care. So, second most common site of hospice care, especially for patients with dementia. Over 50% of patients will die in a nursing home who have dementia. And so, since they're not included in the denominator here, we were curious how this might influence prescribing in hospice. So we did a study to look from 2011 to 2017 using national MDS data to look and see how prescribing has been impacted both in the non-hospice long stay population as well as those in hospice. And this looked at about 4 million long stay nursing home residents. About 800,000 of them were enrolled in hospice for some part of their long stay episode. So what did we find? Again, x-axis here is time, y-axis is the percent of long stay residents with antipsychotic use. And then again, we're broken up into the pre-CMS National Partnership, which again was that antipsychotic reduction initiative, and then the introduction of the 5-star quality rating system that incorporated antipsychotic use in 2015. So starting with the non-hospice population, we've seen about a 30% decline in antipsychotic prescribing over time following these initiatives. When we look at hospice, we really see parallel decline. So there's also been a 30% decline in antipsychotic prescribing in hospice as well. So some studies I'm currently doing, so that was using national MDS data. We're now replicating this using claims data, using Part D and medication data included in the hospice claims files, and we're finding the same thing. I'll just highlight that we've also looked by specific diagnoses. So even though these initiatives were really intended to help patients with dementia and reduce potentially inappropriate antipsychotic use, even nursing home residents with cancer who are enrolled for malignancies, the slope before, you can see that's antipsychotic use prior to the start of the reporting period, afterwards significant decline. So definitely spill over to other populations as well. And part of my work is mixed methods and doing qualitative interviews. And through a study where we spoke with hospice prescribers, so physicians and nurse practitioners nationally, here were some of the things we heard about some of these location of care factors. So sometimes you have to treat home patients versus facility patients differently because of the restrictions of facilities. So I might make a medication choice that I wouldn't make for a home patient that I'm sort of forced into making because of a restriction. Another participant said, patients in skilled nursing facilities, we don't just pull out Haldol there. It's a big problem because of their regulations and the documentation that has to occur. And then lastly, anytime I've tried to write for Haldol in the nursing home, I get a call back. You can't write for this. You have to come up with something else. You also can't write for this. They would be tending to ask, what about Depakote or something like that? So we hear this a lot from clinicians as well, that this does make factors into the decisions about what medications they can use in those settings. So currently, we're working on some studies to look and see how this impacts the care that patients receive in nursing home settings. So does this reduction of antipsychotic use actually negatively impact end-of-life care? So I'll shift now to talk a little bit about some of my research evaluating claims-based prescribing in hospice, which is the focus of my K23. So there were several things that really got me interested in this area of looking at prescribing in hospice. And I think there's really some unique aspects. So one is that we know that these types of medications like antipsychotics and benzodiazepines are routinely prescribed in hospice care. And they're used for both behavioral and physical symptom management, and they're common components of the hospice toolkit and commonly provided through the comfort kit that's dispensed to many patients enrolled in hospice. However, outside of end of life care and hospice, these medications are generally medications that we want to avoid because of a high side effect profile with older adults. There's a little bit of a tension between general prescribing recommendations and how these medications are used at end of life. However, we know that that risk benefit kind of balance and decision might be different in end of life care. And so some unfavorable medication side effects might be more tolerated when patients are very imminently towards the end of their life and trying to balance that comfort and sedation. But we also know that hospice is serving an increasingly heterogeneous population. The benefit was really designed for those with malignancies. We now see significant growth in enrollment in hospice for non-cancer diagnoses like dementia. So Kristen and Lauren have done a ton of work in this area. And some of the studies that Lauren had done have shown that up to 20% of patients actually get disenrolled or kicked out of the hospice benefit. And so for those patients who are not imminently dying, patients and families may wish to avoid use of these sedating medications to help preserve function and cognition for a longer period of time. Hospice also works on a formulary similar to the VA, and where medications get covered is a little bit at the discretion of the hospice medical director. So, whether medications get billed to Part D or they get billed under the hospice benefit is really a decision made by the medical director. And that can be hard to know which medications are considered related to end of life care, especially in the setting of dementia. We also know that there are often standardized order sets and comfort kits that are prescribed in hospice, and nurses play a huge role in hospice care. And a lot of times, prescribing decisions will go through kind of protocols or standardized order sets. So the prescriber might be one step removed from medication administration. There also is very few randomized controlled trials to inform benefit. Oops, there we go. Inform benefit in end of life care. And so, of these trials that have been done, very few of them show kind of robust evidence for use of these medications to treat end of life symptoms. So, for instance, there's been a recent RCT and Cochrane review looking at haloperidol for treating end of life delirium, and really found that these medications not only don't improve delirium outcomes, but patients also die sooner. And so there isn't a lot of consensus or kind of best practice on how to use these medications. It's also challenging to know the right amount of medication use in hospice as well. Like you said, there are very few kind of consensus or best practice guidelines around prescribing of these medications, especially for older hospice beneficiaries. And while probably not all patients who enroll in hospice need to receive these medications, some do, and some of the trouble trying to figure out who those patients are. So there's also some unique data aspects to hospice prescribing. So when I first looked into this, um, I was really surprised there wasn't more out there, and much of what was out there was really limited to survey data or looking at nursing home data using the minimum data set or evaluations of individual hospice agencies. And the reason is prior to 2014, there was no requirement for hospices to list the medications billed under the hospice benefit. So it's been a little bit of a black box. And then, as part of hospice payment reform in 2014, hospices were then mandated to start listing the medications billed to the hospice benefit. So, this allowed for the first combination of Part D medication claims with the information contained in the hospice file to really try to understand the landscape of prescribing in hospice. And this policy reform was really enacted to try to do an audit of billing practices for hospice. So, there were some concerns that medications like opioids were being inappropriately shifted to Part D when they should have been covered under the hospice benefit. So that was kind of the motivation for why this came about. So some of our initial work was just to try to understand how these medications are prescribed. And unsurprisingly, there's high rates of use of these central nervous system active medications during the end of life period and in hospice. And so medications like opioids, benzodiazepines, and antipsychotics are very commonly prescribed to hospice beneficiaries. So, given that there's limited guidelines or consensus on best prescribing practices, we're really interested in understanding potential variation in prescribing across hospice agencies and across the United States. So, we've done a couple studies to use the combined data in Part D and the Medicare hospice to really understand kind of how prescribing practices potentially differ across hospice agencies. So one study we recently did was looking here at variation in prescribing across agencies. So on the left here, we have antipsychotic prescribing, on the right, benzodiazepine prescribing, and these are showing agencies in different prescribing quintiles. So quintile 1 are low prescribing hospice agencies, quintile 5 are high prescribing agencies. What you can see is there's just huge variation in how widely these medications are used. So, in the lowest prescribing quintile for antipsychotics, about 6% of patients enrolled are getting these medications, whereas in the highest prescribing quintile, 64%. Even a wider spread for benzodiazepines going from 12 to 80. So, a lot of variation in what's considered kind of standard practice. We've looked across states as well, so a little hard to read, but the x-axis here is lining up states in order of the frequency of antipsychotic prescribing rates, which is shown in blue, and then red is showing benzodiazepine. So again, very wide fluctuation between how these medications are used. If you're wondering where California is on the list, we're here. So and again, some of the states that have the highest rates of prescribing, states like Oregon or Washington, don't necessarily track with community prevalence of these medication use in the community or in nursing homes. So there are some unique hospice related factors that are at play here as well. For all hospice agencies, use of benzodiazepines is higher than antipsychotics. But when we look at the correlation between their antipsychotic and benzodiazepine prescribing rate, they're actually not that correlated. And so it's not that just every patient is getting a standard comfort kit when they enter the agency. There's preferential use of certain agents. And again, I think interesting to note that some of the states here don't really match with community prescribing patterns. And so interesting to start to think about what are some of those state level factors that might influence this. For instance, things like presence of inpatient hospice facilities and how that might drive some of this as well too. So while we might not know what the optimal level of medication use is in hospice, this wide variation really suggests a lack of standardization across hospice agencies. And this is consistent in areas with other work where there's not a consensus regarding best treatment practices or treatment appropriateness. And so we're also interested in what are the patient factors. So we know the agency factors. What are some of the patient factors that are contributing to this variation? And specifically, when we look at benzodiazepine and opioid and antipsychotic prescribing, we see that some of the trends that we see outside of hospice in terms of CNS active medication prescribing also extended the end of life period. So use of these medications are more common among women, more common among younger hospice enrollees. Patients with cancer are more likely to receive these medications. And then patients in rural areas are more likely to receive these medications as well, more likely to get benzodiazepines, antipsychotics, and opioids. However, some of the largest associations that we see are by race. And so minoritized populations like non-Hispanic, Black, and Hispanic patients are significantly less likely to receive benzodiazepines and opioids during end of life care. And so part of this might be related to patient and family preferences, but it's not hard to believe that racial biases in prescribing that occur outside of end of life setting also influence prescribing in hospice as well. We already know that there's huge disparities in access to hospice and hospice utilization among these groups as well. So we're currently involved in several studies to really try to tease this out. And so, how about other hospice agency factors that are contributing? So, several studies that we've done have found that really the hospice agency that you enroll in has a big impact on the type of care that you receive. And so, we found that certain hospice agency characteristics are highly associated with prescribing. So, for instance, patients who are enrolled in for profit hospice agencies are much more likely to receive antipsychotics and benzodiazepines. And we know that for profit facilities are really driven by financial incentives. And so there is a cost to medications, but the cost of medication is probably less than sending a staff member or nurse to a home to evaluate a patient. We also see issues with larger hospice agencies are also much more likely to prescribe these medications as well as similar to the studies done by Paula Rashan and Chen, we also see that the baseline hospice prescribing rate is a huge independent factor that's associated with prescribing too. So if you enroll in a hospice agency where patients just receive a lot of these medications, regardless of your enrollment diagnosis, regardless of your the case mix of the hospice agency, for instance, with benzodiazepines, you're 10 times more likely to receive a benzodiazepine. So a lot of this is kind of prescribing culture, kind of agency specific factors. And we're now starting to extend this work to try to look at who exactly are the prescribers. So how does the mix of prescriber types impact the types of medications received? Again, so just to mention that some of these studies, we've also controlled for kind of receiving what we call the kit, which is a standardized small amount of medications. And so with a lot of these studies, we're looking at prescription refills to try to get past that question. We've also in these studies excluded patients who are in the active dying period, excluding patients, say, in the last several days of life or last week of life, and all of these types of findings still remain. And so the majority of this variation that we're seeing is really related to factors of the hospice agency more so than patient characteristics. And I think some of the interesting findings related profit status, I think, really beg for more studies. We know that for-profit hospice agencies are now caring for, at least half of hospice beneficiaries. There's been some concerns about the quality of care delivered by for-profit agencies, less staffing, more use of kind of emergency services or hospitalization. And some of the studies that we're working on now are trying to tease apart kind of staffing ratios and kind of access to see if that might be impacting some of these findings as well. And I think it kind of gives us some insights into potential intervention targets as well. All right. couple more here and then we'll take questions. So, lastly, we can only gain so much from claims data. And so, part of my work is also focused on mixed methods and trying to get at the why of some of these findings and variation that we're seeing. And so, really, we know very little about how hospice prescribers weigh decisions for individuals in hospice. And so, as part of our work, we've interviewed hospice prescribers about the factors that influence whether or not they initiate these medications in hospice, and specifically focusing on treatment of behavioral symptoms. So, in a recent study, we interviewed 23 hospice prescribers across 14 states about the factors that really influence their decision to use medications. And probably not surprising to many people here, the patient's caregiver really has a huge influence. And so, time and time again, prescribers would say that caregiver factors, including level of distress, caregiver capabilities, really influence the decision to start medication, especially for patients in home hospice. And if caregivers are distressed, kind of burn out, they're much more likely to initiate medications. We also know that there can be a lot of patient and caregiver stigma and concerns around using these types of medication at end of life. And so often hospice prescribers would say that they felt limited in using medications because folks were concerned about addiction or concerned that these medications would hasten death. So a lot of education around kind of appropriate use of these medications. Also, prescribers talked a lot about trying to avoid kind of burdensome transitions and that trying to maintain someone in the home setting or making sure that someone isn't losing their placement in an assisted living facility really can be a kind of a high decision point about use of medications, and that losing that placement into those transitions can be very burdensome as well. And then lastly, time and time again, issues came up related to nursing home hospice care and unique challenges. So one related to antipsychotic regulations and how that limits medication choices, as well as kind of extra stakeholder involvement. Often hospice agencies will act in a consulting role at nursing homes. And so difficulty of kind of getting collateral and kind of being able to sometimes prescribing was one or two steps removed. So some of the things that have come up in these interviews. So what's next? So related to kind of my research interest related to trends in prescribing and understanding the impact of policy. So I've been really interested in this growth in anti-epileptic use, especially among patients with dementia. So currently putting together a proposal is trying to understand some of these nursing home prescribing shifts related to anti-epileptics, specifically valproic acid and gabapentin, which we know get used for many off-label conditions. And so that study is really trying to understand kind of drivers of these shifts, as well as net health outcomes from shifting to these medications. So are these medications actually any safer than the medication classes they might be replacing, like antipsychotics or opioids? Related to the hospice work and variation in care, kind of the current studies that we're working on are really trying to understand what's driving this variation across hospice agencies and the outcomes related to this variation in care. So, is high prescribing associated with better or worse outcomes for patients, and starting to tease some of that apart? So, a lot of people to thank. None of this work is done alone, and very fortunate to have a wonderful group of mentors and collaborators that I work with. So, happy to take time now for any questions that folks have. Good.
So fascinating, really interesting, disturbing in some ways. So one of your last findings from your qualitative work was the perception among the hospice providers that things are more complicated. With nursing homes, is there any way in your quantitative data to look at and be able to say, well, which of the hospice patients are in a long-term care setting versus at home, and see, okay, to what extent does the quantitative analysis bear out the perceptions you glean from the qualitative interviews?
Absolutely. That's a great question and suggestion. And so we've started to do some preliminary work to look at that. And so we've categorized patients, whether they're receiving hospice care in the community, in assisted living, or in long stay nursing homes, and looking at prescribing. And prescribing rates are significantly lower for antipsychotics in long stay nursing home residents receiving hospice care, much higher in assisted living and community. We've also looked at use of alternative medication classes, seeing higher rates of benzodiazepine prescribing in long stay nursing home residents as well. So some of that has kind of started to show in some of that data as well.
Thanks.
You need to use microphone again, so people don't mind. Any questions online? Definitely.
Sure.
Hi, Lauren. This is really fascinating. Thank you so much.
Sure.
And as Janet was just asking a question, I was thinking about or wondering if you have tried to tease out what medications are sort of started through transitions of care. Let's say there's like a hospitalization event, or a SNF event. To what extent that also impacts then the long-term use of more at the panel level, so to speak, if you've done
Yeah.
anything in that direction.
No, that's a great question. And we know that many of these medications can be started, say, during an inpatient hospitalization and then just continued indefinitely without medication reconciliation. That's not something specifically that we've looked at, but I think would be really interesting to look at during transitions of care, kind of when these medications are started. One study that we're working on right now is kind of looking at a little bit of the error rate. So patients, specifically looking at patients with dementia enrolled in hospice who get newly started on an antipsychotic or benzodiazepine, and like Lauren has found, got disenrolled from hospice, and then who stays on the medications, where we've kind of gotten an error rate where we thought someone was kind of in a terminal stage, but they're not. But I think looking at transitions from SNF stays, hospitalizations, that would be really helpful as well.
Thank you so much
Hi,
for this
Krista.
great presentation.
Sure.
You know how much I love your work. You a couple times alluded for controlling for the comfort kit. And I feel like that is the number one comment I get when I present about hospice and dementia in the geriatric circle is, have you ever been able to look at the association between use of comfort kit and outcomes?
It's a great question.
Or comparing the places, the agencies that use the comfort kits versus those that don't, that do it just off a formulary.
Yeah, no, that's a great question, and definitely something that we want to look at, but haven't quite delved into yet. So I think it would be really interesting to look amongst kind of these high prescribing agencies. How many of them is it? Okay, everyone who comes in, they receive this pack of medication. We are looking at outcomes to some degree. We're doing some studies looking at long stay nursing home residents and looking amongst those who receive these medications. How does that track with mortality? How does that track with falls? How does that track with cognition? And then also using some of the behavioral information contained within the MDS assessments to see, does that actually improve behavior? So we can look at things like agitation, kind of disruptive behaviors, and see how use of these medications track there as well.
Thanks so much for this wonderful talk. I'm a neurologist, and one question that came to mind is just if you've done any work in dementia subtypes. And your work is really interesting in terms of just trying to get it. I really liked your slide about how etiology matters, and I'm wondering if you have any creative suggestions for how to get at etiology in administrative data sets. So like dementia subtypes, or like looking at history of mental health, acute psychiatric hospitalization, or other things that might imply that the use of those meds might be appropriate, because it's just such a tricky problem.
Absolutely, especially with claims data. So for the first point, we haven't looked by specific subtypes yet, but I think that would be kind of a very natural kind of extension. So, especially some of these medications, like in certain dementia subtypes, like Lewy body dementia, we have a lot more concern about using medications with high dopamine kind of blockade, and think, preferentially about other agents there. For most of what we've tried to control with, exactly looking at previous kind of psychiatric kind of diagnoses within claims data to look at other reasons that these medications might be appropriate. Even when we control for kind of baseline psychiatric diagnoses, we still see a lot of this variation kind of in use. But most of what we've done is kind of based off of diagnosis related. But I do think there's some interesting work to do to kind of further specify kind of how treatment might differ across some of these different subtypes.
Thanks.
Cool.
Yeah, it's super intriguing. And what I find interesting about the variation in the prescribing, and you mentioned this, or I think one of your comments opens the can of worms of, are people prescribing as a way to maybe stave off the next level of care, right? It's like somebody's in assisted living, you really want to avoid the nursing home, maybe you can't even afford it. And so, right, families might say, yeah, let's try the gabapentin for their pain management or whatever. Of course, we don't want to do opioids, so everybody does gabapentin now. But in the end, for this variation, that observation, along with your comments about we don't really know what would be kind of an optimal rate of prescribing, I find really intriguing. So I'm curious, like, how would one potentially answer that question?
Yeah.
Is it in administrative data or, and then I'm an economist, so I'll use econ terms,
Yeah.
then every family and every individual who is living in nursing homes or whatever has a different utility function, right? Like
Exactly.
their
Yep.
willingness personally to feel kind of zonked out,
Yep.
to not have pain versus, like, yeah, I'll take the risk that I'm more likely to fall, but I hurt so much, I'm
Yep.
okay with that or whatever. It's that person-centered outcomes piece. So I'm curious what your thoughts are in that broad, vague domain.
No, and that's what I've spent a lot of time thinking about and trying to think about how do we actually capture kind of meaningful patient outcomes, especially when there's so much kind of variation in this risk benefit profile across patients and the setting of care that they're in. And you mentioned assisted living. I mean, that's something I've spent a lot of time to think about as well, is that often we're enrolling patients in hospice sooner in assisted living to help try to provide some of those supports. And there's a lot of issues around who can actually administer medications and trying to avoid transitioning someone to a nursing home for all those reasons that you mentioned. So it's hard and challenging. And that's what makes it kind of interesting and trying to think about that in terms of getting at an appropriate base rate. I think that's going to have to come from consensus about like who do we think is kind of an appropriate population to kind of receive these medications. It is at least at some kind of base rate, and then understanding that that risk benefit ratio may shift depending on someone's location of care. So someone's threshold for tolerating those side effects might be much higher in the home setting than it is in a facility setting because of those other resources. So don't have a great answer yet, but something we're thinking a lot about how to weigh in kind of those different factors. Be interested if folks have other good ideas about how to do that too.
Lauren, this was a terrific talk, and I was really struck by your use of different methods, the mixed methods approach, and I also really liked how you framed non-pharmacologic interventions as more kind of supportive interventions in this clinical policy environmental space. I was wondering if you had suggestions on kind of where we go from here in terms of policy or clinical interventions. It seems like we've focused so much on kind of penalizing nursing homes, and I wonder if there are different approaches that you would recommend.
Absolutely. And so, as part of our work, we recently convened a Delphi panel with dementia care experts across both VA and non-VA settings to talk about, what are the best ways that we could think about including more inclusive dementia quality metrics. And I think as one of the panelists said, embrace the chaos. It turns out to be very hard to get agreement on folks on what these quality metrics should be. And I think where you can kind of make that nudge to try to move people towards more appropriate care can be hard. And, we proposed other quality metrics, like things like including more comprehensive kind of measures of overall kind of medication use, including anti-epileptics, benzodiazepines. And folks are just worried that that's just going to shift prescribing to yet another medication class. And so if there isn't an avenue to help support caregiver interventions or kind of staff training to do some of these non-pharmacologic, you're going to keep kind of moving to other kind of easier kind of methods. And so I really think there needs to be an incentive to incentivize kind of the time and training needed. And so Helen Kales is someone who I've worked with a lot, who's developed with collaborators at Hopkins what's called the DICE method. And so they've kind of done intervention studies that can be done at a tablet level, that you can train kind of long-term care staff to deliver non-pharmacologic interventions by putting into the tablet what are the behaviors you're seeing, and can give you a behavioral prescription that can be done and then tried and feedback what worked and what didn't. And so I really think an incentivization of the time needed to train caregivers and to be able to provide that is really what's needed. And I think the VA is really a leader in that space. So if you think about STAR VA and some of the interventions that they've done, they can really be a model for us and other systems as well too.
Thank you.
All right.
Just a quick shout out. I think you're meeting I know you're meeting Laura
Yes.
Wagner at some point. She's doing research on training for dementia care in
Right.
nursing home staff. Might be some interesting opportunities there.
Fun.
So I think, are we done? Okay, we are being told that we are out of time. So thank you to everybody who came.
Yeah.